welcome to Back Medicine with Miss P. And today we're going to talk about the abdominal cavity or your abdomen. So we did breath sounds last week, so we're just kind of working all the way down here. So today when we talk about your abdomen, I know everyone says like, how's your stomach feel? I'm going to pressure on your stomach or, roll over onto your stomach. That's one of my pet peeves. We never say, hey, can you roll over here onto your pancreas? Or, I need you to roll to me onto your intestines. Nobody ever says that. We always say your stomach as if that is your whole stomach. It's not. Your stomach is a very small fish-shaped or fish-sized organ underneath your xiphoid process. The rest of your abdominal cavity has a buttload of other things in there that are really important, and that's what we are assessing. So when we talk about the abdomen being soft and non-distended, we're making sure it's soft, so we are ruling out any sort of built-up of pressure, either from fluid or a hemorrhage or even gas from either your intestines or some sort of rupture from an organ that's been infected. So when we talk about the abdomen being soft, you're going to push on it like you do with the doctor, right? So you've been to the doctor and you can tell that they're trying to feel your spine through all of your vital organs. That's the right way to feel someone's abdomen. So you kind of pushing on those four corners like you're playing Foursquare or Simon Says. That's not how that works. You have to push like you mean it to see if there's any pain upon palpation, rebound tenderness, or any masses or anything that you can actually feel through that abdominal cavity. And I know it's hard with a very large person or that big round kind of grease belly that some of these men have and that sort of thing, but you have to push like you mean it. It's not going to be super comfortable, but it's only going to be for a minute. They're going to survive. And I know, especially those who have been to a gynecologist, notice how they have one hand in and one hand on top, and they're trying to almost see if they could meet those fingers, right? Super comfortable, right? Yeah, just for a minute. They have to make sure they're holding that ovary still with the other hand so they can palpate it with the internal hand, right? You're kind of doing the same thing, but nothing internal. You have to feel those organs like you mean it. You are looking for something or anything that's abnormal upon palpation. That is why we talk about the abdomen being soft. Now, I don't mean that big round beer belly or that fast food fat gut. I mean soft as in if you push, you can get some depth there. That's what soft is. Don't get confused when we talk about distended or firm abdomen. When you palpate a firm abdomen, one of two things are going to happen. You can palpate a firm abdomen because the patient is already either dead or catatonic or in a coma or something like that. Because if you were to attempt to palpate a firm abdomen with your hand, you're probably going to get swatted away with cat-like reflexes, even if this lady is 91 years old. The pain is excruciating. If you've never had a little gastritis or duodenitis or just enteritis, any inflammation of the GI tract or any sorts of appendix issue or anything like that, pain is not the word for it. Visceral pain, nerve pain is bad too, but visceral pain you can't make better. It's so deep and so miserable that if you think they're just going to lie there and you're like, oh, her abdomen is firm while she was watching Price is Right, that's not a firm abdomen. Now, maybe they were tensing up or kind of fighting against you. That might be a little less soft than you expect, but a firm abdomen means something inside has created such pressure that there's modeling or rigidity of the muscle wall as well as the peritoneal cavity. So that's somebody that's already had a rupture or some sort of intestinal issue or an organ problem. The only three things, that's what I tell all my students, the only three things that follow a true firm and distended abdomen is you are now taking that patient to L&D because she's about to deliver a baby. You are heading to the OR because either something exploded or they've got massive liver failure and ascites where you're going to pull out $5,000, 5,000 milliliters of fluid in their abdominal cavity, which didn't happen overnight, right? So that might be firm and distended, or you're going to the morgue. That's about all you're going to get when we talk about firm and distended. So make sure you're palpating correctly and that you're looking at the patient as a whole when you have an abnormality in the abdomen. There's so many organs in there that could be problematic that if you think there truly is an issue and you palpate and they have, no significant pain upon palpation or rebound tenderness, what you think is a firm abdomen might just be that big round gut. And it's okay to say that. It's okay to say soft and round. Then we're going to listen for bowel sounds, right? You've got to have some movement in there. It's never going to stop. Even though I have patients constantly come in and say, I need urine from them. And they're like, well, I haven't had anything to drink in, 6 hours. I'm like, it's a waste product. It's always going to come out unless you're like significantly dehydrated. And even then you can still produce urine. It's just going to be, maybe a lot, darker and concentrated in color. You're still going to produce waste, whether you like it or not. If you were living and breathing and working and moving, you're still going to produce waste. So that intestine should still be moving no matter what. Those sounds should still be there no matter what. And if you can't get any sound after 5 minutes in one quadrant, I'll even kind of palpate the belly first. I'll kind of get in there and get things moving a little bit and then listen. And I know some people say, it's the other way around, but if you can correct it by just moving with your hands and palpating it, how critical can it be? If you want to sneak up on there and don't touch anything and see if anything's moving before you get in there and stir the pot, that doesn't mean it's not fixable. If you can go in there and do some abdominal massage and help them poop and help things move, and that's what we're supposed to be doing. So if you've got a patient that has chronic constipation, all kinds of issues like that, and they're bed bound and they can't get up and get walking, then you're supposed to be doing abdominal massage. You're supposed to be increasing their fiber, their fluid, and activity. And if you can't increase their activity, then you should have them do abdominal massage, push and move on them as much as you can, or you should be doing it, right? What do we do when a baby's colicking? We take their little feet and bend their little knees up into their gut to move things around, right? Because the doctor doesn't know how to tell you to, with your hand palpate and move their belly around. Now, I did it with my kids because I know how hard or how soft to move, but they tell you just take their feet and kind of push their feet because you're mimicking that walking activity. You're mimicking that movement and getting those intestines going. So make sure that abdomen is soft and non-distended. Now, when we talk about non-distended, that can be a little confusing also. It's unlikely that constipation would make you distended. That would be a whole lot of stool in your 6,000 feet of colon to cause that issue. Distension is generally from gas or that sort of thing. It could be from a blockage that's not allowing that gas to move, and that's where you get the distended part. But almost every night before I get in the shower, I feel distended. I could look down and feel like, oh my gosh, what did I eat? And that's just because I downed a whole box of Triscuits and my spinach dip, and there's something in there that's makes me feel distended. Or throughout the day. Now I wake up in the morning, I'm all sorts of flat bellied and like, hey, I should be in a bathing suit. But come that night, I'm like, oh my gosh, what did I eat and what happened? So that's a normal constant movement throughout the day, and you should expect that. So if you have a patient that's distended and there's no amount of abdominal massage or movement or repositioning, that sort of thing that can get that thing moving around, and she's complaining of abdominal pain, or you can see charted wise that she hasn't had a bowel movement in 2 days or so, well, then we need to treat that and you need to do something about it. You can't chart an abnormality and then just like continue on to range of motion and that sort of thing. You have to stop where you are, recognize that if there's a problem, it needs to be treated. And that may be something that you find on your exam. So make sure your assessments are very detailed. I always kind of, remember what I say, just kind of laser beam them all the way down, and any abnormality, you stop and chart it and do something about it. And if it needs treatment immediately, treat it immediately. Stop your assessment, fix the problem, note it, and then begin your assessment as if that's the date and time of when you started your assessment. You're not going to stop your assessment in the middle because it's just an act. You're not charting it right now. So if you walked into a patient's room and started to ask their name and date of birth and if they knew today's date and why they were here and that sort of thing, and you started your assessment and they're having problems breathing or anything, you would stop your assessment, help them with the breathing, help them with their pain, clean them up if you walked in the room and you could smell that they needed to be cleaned up, and then you would begin your assessment later. Same thing here. If you found something abnormal, I might stop. I'm not going to get rid of all that information I got from this point, but I'm just going to kind of store it in my head, and then I'll fix whatever issue it is if it's fixable. And I may chart something like, upon beginning head to toe assessment, patient complained of abdominal pain and was noted to be, the abdomen was noted to be soft and somewhat distended with some discomfort upon palpation or rebound tenderness or whatever you might say. Let's hope not rebound tenderness, but whatever you might describe it. Patient states she has not had a bowel movement in 2 days. This was verified by charting or text or, whoever was there to help you. And then this is how we treated. And of course, we encouraged significant fluid, right? Quit putting the water at the bedside and expecting that they're going to drink. So you have to be the one setting them up, holding that straw, making sure they're drinking. And then you would go back, once that was maybe corrected, not that they're going to have a bowel movement right then and there, but maybe you could say like, we'll continue to monitor and, assess and encourage fluid and activity. We'll reassess in 1 hour or, a couple hours, whatever is realistic for this person. But make sure that if you find something abnormal in your assessment that you treat it immediately, or at least take care of it, or maybe even note it. Will further assess, see note below, and then you can write a note when you're finished with your assessment. There shouldn't be any interventions in the middle of your assessment, basically, is what I'm saying. So it's really important that you recognize that abdomen should always be soft and non-distended. And you also have to be specific in what you find. If they're morbidly obese, don't tell me soft and non-distended. I'm soft and non-distended. You're soft and non-distended. Someone that's 400 pounds, that is soft, non-distended, and morbidly obese with multiple abdominal folds or multiple skin folds. Let's say they lost a lot of weight. Or if their abdomen is concave, and this little emaciated lady who's skin and bones who lost her appetite 6 months ago and we're, jamming Ensures and stuff in her. Don't tell me that's soft and non-distended when it's concave and you can see her ribs. Be specific. I need to read that assessment and, or the prosecuting attorney needs to read that assessment and it has to match that patient in bed. So whatever you're writing has to be very specific to what you find in bed with details, and recognize not only where those organs are, but what you're feeling for. And you have to push like you mean it. I distinctly remember like it was yesterday, only it was 100 years ago. I was working at an OBGYN office, and every afternoon I would go get McDonald's, as you can when you're 20. And then about an hour or two later, I would have to walk around and hold my gallbladder. Like I would just jam my fingers up underneath my ribs, and everyone's like, what's wrong with you? I'm like, I don't know. Well, fortunately, we had a sonogram gal right then and there with the equipment, and she checked. She's like, yeah, you got gallstones. So I stopped eating McDonald's every day. Now, not that I don't still do it, but I don't know where my gallstones went. I don't care. They're gone. That's the important thing. Or I don't feel them, I should say. But like, that will kind of tell you exactly where your organs are. You need to know, and I will forever remember where my gallbladder is and know that the liver's above that, and and your pancreas on the other side, and your 600 feet of intestines and that sort of thing. You need to know what you're feeling for and not doing it because, your instructor at the front of the room said, feel this and this is how we do it. You really have to get up in there and put pressure on those areas and make sure that you don't feel anything that you're not supposed to feel. And if you think you as students or, early on nurses don't find stuff, you're wrong. I've had students find things and bring them to me. And, I guess kind of at first I'm like, well, probably not, but let's go check. And I always go check, and yeah, you found something. And there's nothing wrong with that. It is really important. One of the students found, not only was it a little swollen, but it was red, kind of a little red around it, and we found out how and why that happened. And it was a bad situation. It was a significant med error, and we got to the bottom of it, and the patient was okay. So that's probably all I'm going to get into too deep here with your abdominal cavity. Just recognize that your pelvic cavity is not your abdominal cavity. They're separate. So that bladder distension, that sort of thing, that's a little bit different issue. So recognize when you get those types of things. And, don't be afraid of being specific. If they have that redness or that, kind of fungal rash, not that we can diagnose that, but we can describe it, where you see it and how. If there's anything abnormal, don't miss it. Make sure that you're very specific with those things. There's a whole lot that can go wrong in here, and you need to recognize that. So, your ascites patients are going to have that shiny, taut skin to where you can all but fix your lipstick in their abdomen because it's that tight, and they'll come in every so often to have their centesis. Will draw out, 3, 5, 8,000 cc's of fluid from their abdominal cavity. And then they're like, "Ooh, I can breathe much better now." And then they go home and we see them back in a little while and do it all over again. But recognize that, anything, if you truly think that their abdomen is firm or distended, that you maybe go get someone else in there and say, "Hey, can you come check this with me and tell me what you think?" I've had one student in almost 15 years come to me and say, the abdomen, was firm. And I'm like, let's go look. So I go look, and this gentleman is sitting in his wheelchair. Now, granted, he's in his wheelchair and he's kind of humped over, but like the upper portion of his abdomen which I would get him back in bed, to do a correct assessment. But this is kind of, sometimes what we have to do if they refuse. We're guests there. We're not going to force them back in bed if they're, combative against it. But she did a pretty good job. And his abdomen was, God forbid I say firm. It was a little less soft than I would expect. So what we did was just a detailed assessment, and we kind of made a note about it. And then we told the LPN, who told the NP, and they got an ultrasound, and they said, like it was significantly, it was really weird. It was just like firm on top. And then the rest of his abdomen wasn't, it was pretty soft, but he had this like kind of little shelf, this little lump right here. And it was firm. I mean, it was, when you pushed on it, it didn't really give. And I thought, well, he's not in any pain, so I don't know what it is. He had a bunch of other issues, this weird, flaky, rough skin thing, like flaky, like I've never, like in the movies, flaky skin, like a sci-fi alien shedding kind of thing. I've never seen anything like it. It was rough. So I didn't know if there was maybe something, kind of some autoimmune disorders kind of create induration in tissues and that sort of thing. So, but we did get it all checked out. So that's what the note said. And she made a specific note that says, this is what I found, this is who I told, this is what we did, and this is, the conclusion of it. So you always have to API all of those notes, right? Assess, plan, intervene, and evaluate. So she made a little note and it was fine, but that was like the one patient that I could say, did not go to L&D, the morgue, or the OR, but it was this significant abnormality. And we did explore all options and, get to the root of it, or rule out, concerns. And he was fine. He wasn't in any discomfort. And that's how you know, because if ever you've had any sort of enteritis or abdominal pain, it's like you can't have your clothes touch you. One time it happened to me. Ramen noodles is not real food. Don't eat that crap. It's not real food. It's plastic. It's plastic on the way in. It's plastic on the way out. Don't even just Google endoscopies with ramen noodles. One time I had that, and I thought I was going to die. And I can only assume that they maybe snuck in like shards of glass or small razor blade pieces, because my intestines hurt for weeks after. I was miserable. And one other time in my life, I don't know what I eat. I don't think it was the ramen noodle. It could have been, but this was years ago, I think before I had kids even. And I let the only doctor there that was like a general surgeon who didn't even speak English assess me, because I thought I was going to die. I mean, like I was sitting at the desk, tears are rolling down my face, to like, what's wrong with you? And someone like put their hand on my shoulder, and I kind of like jumped away from it, and they kind of jumped, and they're like, what's wrong with you? And I'm like, I think something exploded in my abdomen, tell my husband I love him, please take good care of my horses, because I thought it was over. Like I can't even describe the pain. Intestinal or visceral pain. Now, I haven't really ever had not real bad nerve pain. I mean, I've had like fever blisters, which if you touch them, you see stars and stuff, but thank God I haven't had really bad nerve issues. I hurt my back one time, and that was pretty rough. But visceral pain, it will overtake you. I remember even my father had a bout of gastritis, and he said he was very animated. And he said how he like stripped all his clothes off and freaked out, and then someone gave him like a swallow of milk of magnesia or Maalox or something, and then it like immediately cured him, and he bought a case of it, and then probably never needed it again. But I got one shot of Toradol in my leg. And granted, it felt like fire, and I thought I was going to die for a second there, but then I was immediately cured and good to go, work the rest of the day, no big deal, and hadn't had a problem since, years later, the whole ramen noodle episode. But if someone truly has a problem, they're not going to pretend like it's okay. They're not going to say, oh, I'll be all right. It's all but debilitating. So be real careful when you chart something that you think is abnormal, and the patient's subjective and objective data will really help you kind of guide whether that patient needs immediate assistance or not. Okay, so that's probably about it with your abdominal cavity. I'm sure we'll hit on something else later on, but we'll end it with my little pet peeve, and this isn't too bad, only 19 minutes. Pet peeve, okay, this is real simple. When you cross the road. Don't walk down the middle of the road while I'm waiting for you to get out of my way so I can continue on. For the love of God, have some consideration. Cross the road, not diagonal the road while I'm waiting to move. It's annoying and it's rude. Have some consideration. Okay. All right. Love y'all, and we'll hit range of motion. Oh my gosh, range of motion next week. Focus, y'all. Spread the word. Range of motion. Nobody ever charts it correctly, ever. So let's nail it next week. Okay. Love you guys. See you soon.